Good afternoon, dear students. I am Dr. Saqib Ahmed, Assistant Professor of Radiology of the Said Medical and Dental College. My today's presentation or lecture is regarding the radiology of urinary system. Since there are so many diseases and conditions which involve or can involve the urinary system, this discussion will be divided into 3 different lectures. Now we are today discussing the first part of this discussion. And you will note that at the end of this discussion there will be a small assignment, and if you read or see carefully all these investigations, you will find the answer to that question. Now the first image is CT urogram. This is a colorful image, but this is a real one. You can see the kidneys, you can see the ureters coming down in the lighter color, and the urinary bladder which is filled up to its extent with the urine. Same patient, axial image, but here you can see a small renal mass in the left kidney which is depicted by the white arrow. Now this is MR image, coronal image of the abdomen, which shows the kidneys, and here you can see clearly the different organs having different intensity. You can see the kidneys, liver and the spleen, and a rounded bright structure in the top of the right kidney is actually a simple renal cyst. This is MR urography. Again you can see different structures, and the ureters along with the dilated pelvic calyceal system, they are outlined, and the bright thing in the ureter is the urine. Now in case of MR urography, we need not to give contrast to the patient, so we can see the fluid, for example urine in the urinary system, which appears bright or hyper intense. And similarly, if you look at the large gut in the periphery of this picture, you can see the gray scale. This is the fluid in the large gut mixed with the stool. Now this is an axial, these are the axial images of the abdomen taken at the renal level. You can see a lymphoma with different densities, the MR image, the CT image, and the nuclear study. So we can see the same lesion in different modalities. Now this is how the fetal kidney looks. We can very clearly image the kidneys of the fetus when it is in the intrauterine life. So any disease involving the fetal kidneys can be very clearly picked up. This is the axial image through the abdomen of the fetus. You can see both kidneys, you can see the spine. This is actually an axial image like we have in the CT scan. Again, intrauterine study of the fetus with dilated renal pelvic calyceal system, moderately dilated renal pelvises, and these are the structures due to the bilateral pelviureteric junction obstruction leading to the dilated renal pelvises of the fetus. Now this is a different grading, mild pylectasis, and on the right of the screen there is hydronephrosis, where you can see the difference where there is moderately dilated renal pelvises. Now, after birth, when there is a suspicion of pelvic obstruction, the contrast study of the patient is performed, and you can see grossly dilated extrarenal pelvis on the left side with dilated pelvic system, no ureteric outline on the left side. On the right side, the system is normal and you can see the proximal ureteric outline. The same patient, axial image taken at the renal level, you can see grossly dilated extrarenal pelvis with PUJ obstruction. Now, fetal polycystic kidneys. In such cases, the kidneys are moderately enlarged with homogeneous echogenicity. We cannot see the cyst, but again it is called polycystic because the cysts are less than centimeter. Most of the time they are very small, so they cannot be seen on ultrasound, but still the kidneys are moderately enlarged. Another view, here you can see the large fetal kidney. You cannot see the pelvic system clearly. This picture is just to show the difference between the echogenicity of the renal cortex and the adjacent liver. Whenever there is a fatty liver, it becomes more echogenic and the adjacent kidney cortex appears rather hypoechogenic. Otherwise, the kidney is normal. Now, a very common problem after the renal stones is the presence of one or multiple simple renal cortical cysts. As long as they are less than 5 centimeters, they are clinically insignificant and they are just seen incidentally. After the age of 40 years, anybody could have multiple cysts in their kidneys without any clinical significance. Its clinical significance arises only when the size is greater than 10 centimeter or when there is danger of hemorrhage into the cyst or rupture or infection. Now this is a renal cyst. Doppler is on and you can see the renal vessel surrounding the renal cyst and there is no flow inside, so it means this is a cystic structure. Again, CT scan of a large renal simple cyst. This is a huge cyst and the cyst at this stage may become problematic. They are prone to infection, they are prone to rupture with trivial trauma, or hemorrhage can occur inside the cyst. Renal abscess. The only difference in simple renal cyst and the abscess is the presence of internal echoes in the renal abscess, where they are totally absent in the renal cyst, where there is clear through transmission. Now these are the multiple perinephric abscesses. rounded structures with internal echoes and small perinephric fluid collection. Now adult polycystic kidney. When the patient comes to the department for ultrasonography, at that time most of the kidneys are grossly enlarged. Sometimes they are filling the whole abdomen and it becomes impossible to take the exact size of the kidneys because they are all replaced by the numerous cysts of variable sizes. Now this is the intravenous pyelography. Actually this is a retrograde outline of the system in which you can see the pelvic ileal system is displaced because of the presence of the multiple cysts. We cannot make out a normal pelvic ileal system. Axial image at the level of the kidneys, you can see the pancreas and the liver, and both kidneys are moderately enlarged with bilateral cystic lesions of variable sizes. Contrast was given and the contrast is taken up by the normal parenchyma which is left. Aneurysm of the renal artery is not very common problem, but when it occurs, it may have the ultimate problem with the renal function. Here is the picture. On the left of the screen, it's a right kidney, you can see the liver. The rounded structure on the left side is just dilated renal artery, and on the right of your screen, when the Doppler is on, you can see this is all filled with color and it shows moderate renal artery aneurysm. Now the kidneys have different abnormal anatomical locations. Both kidneys may be on one side. This is called renal cross ectopia. The kidney may be in the pelvic region. This is called ectopic pelvic kidney. And the kidneys are sometimes malrotated, and further we will see case of horseshoe kidney where the kidneys are united in the center, showing the appearance of horseshoe structure. Here you can see in this picture the uterus, the urinary bladder, which is darker, and on the left is the right pelvic kidney. Another case in which intravenous pyelography is performed. Here you can see the normal pelvic ileal system on the left side. However, the kidney is slightly malrotated, but on the left side the kidney is really down in the parapelvic region and malrotated, slightly dilated system. The ectopic kidneys are prone to have renal stones because of their position and because of their stasis of the urine and formation of stones in the ectopic kidneys. Bladder extrophy. This is a congenital condition, maybe sometimes it's traumatic, but here you can see widely open pubic symphysis and the bladder is outside and the ureter is outlined, which is showing some reflux. Now here is the horseshoe kidney. You can see the kidneys are malrotated and they are more towards the spine, and their lower poles actually they are united in the center. Here you can see the CT picture which shows more clear picture of the horseshoe kidney. As you can see the both kidneys united in the center. You can see the ureters coming out from the renal pelvises. The keyhole bladder. Actually, this is a small capacity bladder which may be congenitally small or may have the post-inflammatory condition like tuberculosis or chronic cystitis leading to the small capacity bladder, giving the appearance of old keyhole appearance. Posterior urethral valves exclusively present in the male child. They can be seen when the baby is inside the uterus, and the picture is mostly moderately or grossly dilated urinary bladder, moderately dilated ureters, and bilateral moderate to gross hydronephrosis. On the left of your screen, retrograde cystourethrogram is performed. You can see the bladder and spinning top appearance of the lower segment of the bladder, which is typical of posterior urethral valves. Now this is bladder outlet obstruction. You can see the urine is holding up either in the kidneys or there is reflux and bilateral hydronephrosis. This is urethral reflux as we were talking about. This is another case of posterior urethral valves. If you look at the lower segment, you can see a structure which appears like a spinning top, and both the kidneys, both the ureters are grossly dilated. These are called the mega ureters, and the renal system is again moderately dilated because of the obstruction at the posterior urethra. So this is the case of posterior urethral valve. Different grades of the reflux are noted: grade 1, 2, 3 and 4. This is grade 4 reflux. Sometimes people grade this like grade 5, but from grade 4 to grade 5 the picture is same. The contrast reaches up to the excretory system of the one kidney or the kidneys. Nephrocalcinosis, not very uncommon condition, but here you can see the Malbury appearance in both the kidneys. This is a simple X-ray of the abdomen taken for KUB, no contrast given. Here you can see the radiodense structures filling both the kidneys, and there is one calculus in the right proximal ureter. This is the ultrasound picture of the renal calcinosis. You can see the echogenic structures in the periphery of the renal system, renal cortex. Now, various inflammatory conditions can involve the urinary system, which are acute inflammatory conditions, and those are the chronic inflammatory processes like tuberculosis. It's not very uncommon. In this picture you can see the bladder outline is unclear. There are small sacculations, outpouching, and the kidneys are contracted. Ureters are both holding the contrast, indicating that there is some kind of obstruction at the level of the vesico-ureteric junctions. Autonephrectomy, putty kidney. Now there are sometimes the kidney is so badly filled with the large stone that ultimately the kidney loses its function, shrinks, and there is no function, and this is called autonephrectomy. In this picture, you can count the number of stones which were taken from this kidney after surgery, but still the kidney gone. Another case of tuberculous cystitis, you can see the deformed urinary bladder, outpouching, trabeculae destroyed, and right ureter showing obstruction at the level of vesico-ureteric junction. Another case of left autonephrectomy. You can see the difference between the size and appearance of the kidney. No contrast is excreted from the left side. On the right side, the kidney is normal, the ureter is outlined, the calcium system is normal. Cystogram remains normal. Staghorn calculus. You must have heard about the staghorn. Staghorn is actually the appearance of the stone with the stag, the horns of the stag, different with branching, and it is all filling the renal pelvic-calyceal system. As you can see on the left kidney, where you can see the filling defect in the IVU picture. Stag on the left side along with his horns, and the staghorn calculus on the right of the screen, resulting in moderate to gross hydronephrosis. Another appearance is given to the staghorn calculus is Bear's paws. These are the multiple stones along with moderate to gross hydronephrosis. Another picture of staghorn calculus on ultrasound, you can see the echogenic structures filling the renal pelvic-calyceal system. Renal stone in the renal pelvis. Most of the patients come to the emergency department with renal colic. 99.9% they have stone elsewhere in the excretory system, either in the renal pelvis or in the ureter, either in the proximal and or in the vesico-ureteric junction. As long as the stones are present in the kidney, they usually do not cause any symptoms. But when the stone comes down into the ureter, blocks the excretion of urine from that kidney, then the pain arises because of the stretch of the renal capsule. Another stone in the pelvic-ureteric junction, depicted by an arrow, resulting in the proximal hydronephrosis. Another case, large stone in the proximal ureter, resulting in the proximal hydronephrosis. Now this is the assignment of today's discussion. What is the most common renal problem? What is the radiological investigation of choice in renal colic? Thank you very much.